Welcome, everyone. I'm Dick Deming, Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Cancer Consortium. And tonight you're in for a treat, and so am I. We have my friend and my colleague, Dr. Christian Schultheis, a medical oncologist with Mission Cancer and Blood, and a colleague of mine at Mercy One Cancer Center. Welcome, Christian.
Thank you. Thank you for having me.
So, a local boy, done good. You grew up here in Des Moines, right?
Grew up on the south side on Fleur Drive.
Yeah. And where'd you go to high school?
Dowling.
What was your claim to fame in high school?
I don't know if I had a claim to fame in high school. Just none. I don't think I had a claim to fame. I
Okay.
swam and played tennis. That was the best bit.
Okay, so sports.
Yeah.
And academics.
And academics.
Yeah. Yep.
Yeah. My dad told me I had to study hard, so I did. He said if I screwed up, he was done.
And your father was a physician. He's a physician.
Yep.
Yeah.
He was he's director of the ER at Mercy for 20 years.
So what's that like to be the son of a doc, and especially an ER doc?
It was a lot to live up to because I always looked up to him. I mean, he was my idol and never wanted to screw up, but it was tough always being in his eye.
Was it chaotic at home? Like his hours are off and he needs to be sleeping during the day sometimes. You guys got to be quiet.
Yeah, it was. Yeah, it was. And I remember a couple times he had to run in specifically with when Ozzy Osbourne was in town, and Ozzy bit the bat, and my dad had to go.
Your dad had to go and take care of Ozzy.
He was
Osbourne?
really upset.
Wow. So we know your dad's claim to fame now. You got to come up with a story.
Yeah, I wish I had something.
Wow.
I wish I had something better than that, but I don't.
So did they have to give Ozzy a rabies shot?
He never told me.
Oh, he didn't.
He just told me how to go in.
Confidentiality.
So,
okay.
No HIPAA. It was HIPAA at that time.
Yeah.
Right?
Yeah.
So.
And then where'd you go to college?
Loris College in Dubuque, Iowa.
Okay.
Yeah.
And then medical school?
Medical school. I went to American University of the Caribbean. Was there for 2 years, and then did my third year in London and the first year on the East Coast and one part in here in Des Moines.
Okay.
With Dr. Broker.
And then your internal medicine residency.
University of Oklahoma in Tulsa, and then fellowship, University of Missouri in Columbia.
Gotcha. So by the time, as a medical oncologist, by the time you get through college and medical school and internal medicine residency and then medical oncology fellowship, you must be like nearly 40 by the time you're ready to start practice.
I think I was 32.
32. Okay. Okay. And what's it like to practice medicine in the town you grew up in? We were talking about, Des Moines, 250,000, but it's just like a big little town.
Well, it is growing up on the south side. It's you start to see a lot of the people, unfortunately, that you grew up with and knew. It's an honor to come back. I mean, it's a great city. It was a tough move to move my family here, but it's been wonderful so far.
Because you practiced in Dubuque for
14 years.
14 years.
So my kids grew up there. Yeah.
Gotcha.
Yeah.
So, well, thanks for being here tonight. So we're going to talk about medical oncology and maybe kind of put it in perspective, cancer treatment. How does the medical oncology fit in the world of cancer treatment with surgery and radiation? And how do you usually meet the patient for the first time? And what's it like to actually practice medical oncology?
Well, I can't call it work. To me, I love it. Just like you love your job. I mean, it's, you walk into the room, you can kind of sense how the person's going to be. You kind of sense if you can open up a little bit, if you can joke with them, if you can find something that you can relate to kind of calm them down in that time. So I enjoy that. I enjoy the personal aspect of it quite a bit. The science of medical oncology, just like the science of radiation oncology, is just fascinating, and it's ever changing.
I would say that your field, though, changes so quickly. I mean, we're using the same electrons and photons that existed since the beginning of time. We haven't invented a lot of new forms of radiation. I mean, some, but in medical oncology, I mean, nowadays it's like a new drug once a month.
We're getting emails it's almost once a week. I mean, it's absurd how many new
Mhm.
drugs are out there, and it's sometimes hard to keep up. And then you rely on your partners, you rely on your colleagues, the tertiary institutions, and you just rely on just trying to keep up as best as you can.
So in the scheme of things, there's kind of three general ways of treating cancer, and it's rare nowadays that a patient doesn't have at least two different oncologists. So a surgeon, maybe a surgical oncologist, or it could be a colorectal surgeon, or an ENT surgeon, or a urologist might be on the team. Obviously, the radiation, and then everything to do with treating cancer with medications kind of falls into the medical oncology bucket.
Yeah. Yeah. So it's, are we going to use chemotherapy up front? Are you going to use chemotherapy after surgery? Are you going to sandwich in between? Are you going to potentially use a targeted drug depending on the stage? Are you going to use a hormone manipulation? It has changed dramatically since I started
Yeah.
25 years ago.
So maybe talk about the different types of medicine. So we're talking about using medicine to treat cancer, and most people just kind of lump it all together as chemotherapy.
Right.
But as we all know, there's really different types or classes of medicines that we can
Sure.
talk about that are used to treat cancer.
Sure. So if we can give an example of a certain malignancy, multiple myeloma is cancer of the bone marrow for plasma cells that kind of go haywire. When I started, primarily it was chemotherapy, and it was until I think it was the founder of Walmart. He was diagnosed with multiple myeloma, and his wife approached University of Arkansas and said, "Hey, can you put my husband on this drug, thalidomide?" Which, remember, that was the drug that pregnant women took in the 50s, and their babies were born without arms or legs. And so Sam Walton, that's who it was. And they put him on thalidomide, and it worked. So what the heck? So thalidomide was a drug that blocked blood vessel growth. So if tumors don't have blood vessels, they can't grow. So, and it just extrapolated from there. And then another tumor called a gastrointestinal stromal tumor, we had nothing until, I can't remember, Dr. Drucker in his lab in Oregon had this enzyme or chemical called STI 571 that was a pill that is probably the most purest drug ever formulated in the past 50 years, where it's just, you're taking a pill. And in the original trials, people had disease everywhere. They would do PET scans, and then 72 hours later, they'd repeat a PET scan, and there was already a response. It was amazing.
This is like one of the first medications that was specifically engineered to treat. So it wasn't like an aha discovery. It was actually engineered specifically to attack a particular metabolic process in the
cell,
in the
block ATP.
Yes.
It's blocking ATP, and it was just unreal. And I think that was one of the first drugs that targeted a specific protein, and from then on, it has just, it's been a
So
fact.
before we talk about all the new stuff,
yeah,
maybe explain a little bit what you mean by chemotherapy, like regular chemotherapy. How would you describe how chemotherapy works and what cells it works against, and then kind of some of the collateral damage
Sure.
of like standard chemotherapy that we've been using since, I don't know, 70 years?
At least. Yeah, and Dr. Farber started using methotrexate, what, in the 30s or 40s, I think, when he started doing this stuff.
Okay.
So I always tell patients chemotherapy is kind of like a dumb bomb. It's going to kill tumor cells, but also going to kill normal cells. So
A lot of collateral damage.
A lot of collateral damage. That's why people lose their hair, they get nauseated. And
so it's usually targeting the cells that are proliferating more frequently. Those are the ones that are, and cancer cells do that, but so do a lot of normal cells in the body.
Correct. So each chemotherapy will work at a different level of the cell cycle. Say adriamycin is going to work at the S phase of the cell cycle. Methotrexate is going to work at several different areas of the cell cycle, and it just stops DNA metabolism. So certain block the DNA. So DNA is replicating. It blocks it doesn't allow the DNA to replicate. It's still a great way to treat cancer in certain situations. It's just can be tough on the people. And there's probably about 50 different types of chemotherapy. So when people equate chemotherapy, they're thinking of that movie, and they're thinking of the person at the bedside and turning over the side and throwing up in a bucket. It's not like that anymore, because we're able to kind of block the side effects of treatment while still having a significant benefit.
Yeah. So if someone goes in for, let's say, conventional chemotherapy, it's not like they go in and just get the squirt of chemotherapy. You're often giving them IVs, hydration, IV medicine to counteract the nausea and some of the other side effects. So it's the administration of chemotherapy has changed so much over the last 30 years.
Yeah, it is. It's even changed since, I'd say, 15 years ago. When I started, almost 25 years ago, it's amazing how they've found drugs that can prevent some of these side effects. And nowadays, the incidence of nausea is significantly less than it was even 5 years ago.
And before we talk about the others, if we're just talking about chemotherapy, most people know that some chemotherapy can make your hair fall out.
Right.
That's pretty common knowledge. It can make you throw up. Most people probably know that some chemotherapies can cause peripheral neuropathy. There are some newer treatments now, right, designed to try to help preserve the hair or prevent some neuropathy. What are some of those newer?
So the cold capping. So the common drug we associate with breast cancer to lose your hair is adriamycin. So they've revolutionized a cold capping, where you're using dry ice, and the patient's coming in with a huge cooler, and they're wearing this dry ice while they're getting the chemotherapy. And it really is.
And the theory behind that is
I don't know if I fully understand.
It constricts the blood vessels and maybe
similar to the
decreases
neuropathy in the fingers.
Uh-huh.
So they're wearing, for some certain chemotherapies, they're wearing gloves that are ice, and it prevents the neuropathy. So similar, preventing the blood vessels.
So some of the newer things that you can do with the older fashioned chemotherapy to try to prevent some of the side effects. Then you mentioned the Gleevec, that's the drug for the gastrointestinal stromal tumors, and you call those targeted therapies.
Yeah. So targeted therapies, they've identified how this drug attacks the cell, and then they're studying the cell, and they figure out that cancer is metabolizing that phase, and drug just targets that spot. It's pretty amazing how it works.
And a lot of them are oral, so you don't.
Most of them are oral.
Yeah, which is a big benefit for patients, not having to go in for a 3-hour infusion.
Correct. But I think the one thing that people equate with oral drugs, there's not going to be any side effects, but there's still potential side effects. So even if it's a targeted drug, doesn't mean you're not going to have any problems.
What are some of the other cancers and the drugs that fall into that category of targeted therapies?
So let's go back to, even 100 years ago, they were doing, if we get into immunotherapy, so to say, they've been using immunotherapy on people for years. They would inject viruses or bacteria into people and mount immune response, and they found out that it works. So kidney cancer is one that we learned that responds to more of a targeted therapy, such as immunotherapy.
And lung cancer, for example, I mean, back when I started oncology, it was, you kind of had two types of lung cancer, small cell and non-small cell. And now we have at least 15 actionable mutations that we look for in a lung cancer cell, for which there may be a specific targeted drug. Correct. Or a particular type of lung cancer that has a particular mutation.
Correct. So I think the first one that was identified was in 2004 at Dana-Farber, which was the EGFR. And that drug, I'm blanking on the first drug that was approved, but we were sending all the tissue samples out to Dana-Farber to test for that mutation. And it has, if you have that specific mutation, those patients do better than what they did with chemotherapy. Response rate's probably 70% when chemotherapy is 35%.
It's made a huge difference in the treatment of lung cancer.
Quality of life, survival, response, and just people feeling well.
So you need to figure out before you use a specific targeted therapy, you need to make sure that that patient's cancer cells has the target.
Correct.
So there's some extra steps in that whole process of
Correct.
of diagnosing lung cancer or other cancers.
Right.
Maybe talk a little bit about that genomic testing. And
so I have a lady right now that has she hasn't smoked since 1979, but she has a new lung cancer that's spread throughout her body, and she's not having any symptoms. So we have the luxury of waiting to get these results versus just starting her on chemotherapy. I said, let's wait and get these results because it involves a very small, minute amount of cells. Maybe a millimeter is all you really need to do all these testing to find 30 different mutations. And it takes about 3 weeks to get all those results back. Sometimes we can't wait, but in her, we can wait. So I'd rather not just subject her to chemotherapy, and maybe she's going to have a mutation that I can put her on a pill and she's going to do better. Yeah. But it takes a while. There's several companies in the United States that'll do this, but the turnaround time is just, it takes a while.
That has to be anxiety provoking for patients to be waiting.
You have
to find out.
Yeah. You have to prep them to say, I'm going to send this off, but it's going to be a good 3 weeks. It'll come back in a piecemeal process and I will keep you appraised of this, but be aware it's going to be 3 weeks.
What percent of approximately like lung cancer patients actually have an actionable mutation?
So, it's a small number.
Yeah. So
I'd say it's probably around maybe 10 to 15%, if that much. I mean, it's small. So the most common one is going to be an EGFR mutation. Second one is going to be an ALK. Third one is going to be a ROS1. Fourth is going to be your G2, your KRAS G2R. And then your last one is going to be an NTRK mutation, which is extremely uncommon, except less than 1% of all mutations.
Yeah. And each one of those mutations you mentioned has a specific drug that was, that was manufactured specifically for the target in the cancer cell.
That's correct.
So long gone are the days of just having the pathologist look at a microscope slide and say, yeah, this is lung cancer. This is every lung cancer gets treated the same. Yeah. Now it's just changed the whole face of lung cancer treatment.
It's amazing. It's daunting sometimes to have all that information and let the patient know that I got to wait 3 to 4 weeks to get these results, but you may have that mutation. And the other problem is, and this is another topic to get through, is the cost of these drugs.
Yeah.
It's just absurd how much they cost. It's sickening.
Yeah. Fortunately, most of the companies that make the very expensive drugs have developed sort of foundations that allow some grant money to help for those patients whose insurance doesn't cover it.
That's true. And so our office is able, I'd say we probably acquire close to $2-3 million in grants for patients per year. So to pay for their drugs.
Okay. So that's targeted therapy. Let's talk a bit about immunotherapy. So what is immunotherapy?
Immunotherapy is, I think the best way to say it is, I think there's a theory that cancer is always developing in our body, right? And we have these certain genes called tumor suppressor genes that the DNA is replicating. It makes a mistake. That tumor suppressor gene is going to stop that DNA replication, throw it out, and start again. In some tumors, those tumor suppressor genes are not working. So cancer just grows uncontrollably. And when that happens, your own cancer fighting cells cannot see that cancer growing because, so to say, the door is closed, so to say. So immunotherapy is a drug that you infuse into the patient. They're binding to certain receptors that are commonly found on the cancer cell and allows that door to open, and your own cancer fighting cells go, oh, there it is, and starts fighting the tumor. So it's kind of a targeted drug, so to say, but a smart way to let your own immune system to kind of fight against it.
So it revs up your own immune system. And so that the medicine that you're giving the patient doesn't directly kill the cancer cell. It revs up your body's own ability to rev up your immune system and for the immune cells in our body to actually see the cancer cell better and
That's
attack
correct.
it.
That's correct. And the benefit of that, it doesn't have to be, doesn't have to cross the blood-brain barrier. So certain chemotherapies don't cross, you have a blood-brain barrier, and certain chemotherapies are way too big. They can't cross it. And immunotherapy doesn't matter because your cells are going to be able to cross that blood-brain barrier. So even if you have disease in your brain, you could potentially get a response by that immunotherapy.
That's been huge, especially, I mean, certain cancers. Jimmy Carter, bless his
melanoma,
soul,
yeah.
is 99 years old and has had metastatic melanoma with brain and liver metastases for over 10 years on immunotherapy. I mean, before immunotherapy, melanoma with liver and brain metastases would probably survive 6 months, maybe. And now with immunotherapy, we rev up the bodies. It doesn't cure the cancer. It might.
Maybe. Well, you and I share a patient that had metastatic lung cancer to her liver and bone, and we treated her with immunotherapy in combination with radiation therapy, and she's not been on treatment for 5 years.
She's been off treatment.
Off treatment for 5 years because her cancer's gone.
Yeah.
So,
and in some cancers, you maybe just sort of keep it under control, because in other cancers, maybe you actually do get a cure with the immunotherapy.
I have 2 patients with metastatic melanoma that was ever in their body. They've both been off treatment for 3 and 4 years because their cancer's gone.
Wow.
Is it truly cured? I guess we don't know that yet. Maybe over time, the next 10, 15 years, maybe that cancer is going to come back again. But
maybe the immunotherapy trained our own cells to be better at recognizing
it. Very well could be. I think some of those patients are cured. At least I like to think they are.
It's huge change in the way we feel.
It's unreal.
And then a lot of this, so we also participate in clinical trials research where we enroll patients. And so we may have the best treatment right now is chemotherapy with some immunotherapy afterwards. And we're going, well, maybe we should bring immunotherapy up front. So lots of studies now combining. So rather than saying, well, we're going to use chemo or we're going to use target or we're going to use immunotherapy, we're now kind of mixing and matching a bit.
Correct. And I think there was an early nesting trial at University of Chicago in patients with melanoma, because there were certain patients who responded better if they had certain bacteria in their gut. So then they were randomizing patients to take a probiotic that had that bacteria with immunotherapy versus immunotherapy alone. So we're waiting on those results. So, I mean, there's so many things we're learning about the body and how it can respond to certain medications.
What are some of the side effects that can happen with immunotherapy?
So if you think about it, if immunotherapy is there to rev up your immune system to fight the cancer, that immunotherapy can rev up the immune system to fight against you. So some patients can develop rheumatoid arthritis because they can't move their joint. They're so stiff. Some people develop severe diarrhea because you're calling a colitis. So anything with the itis on it is inflammation. So you're causing a colitis, a dermatitis, a rash, a hepatitis. They get inflammation in the liver, a pneumonitis, kind of chemical pneumonia. Or the most common thing we're going to see is a thyroiditis. So some patients may develop hypothyroidism. The thyroid's not working very well, or hyper, it's working too well. You either need to turn it on or turn it off. Now, that is a pretty mild thing that we can treat. When they get that colitis or that pneumonitis or that hepatitis or that rheumatoid arthritis that is affecting their quality of life, that's where it can be a problem. Mm-hmm. Now, those side effects are rare. The thyroid, I'd say that happens probably 60 to 70% of the time.
That high?
At least in my experience, it does.
And how do you manage the thyroiditis?
If it's hypothyroid,
you give them some thyroxine.
If it's hyperthyroid, you gotta turn off that thyroid.
Okay. So that is not a reason to stop the immunotherapy. You can
definitely not. Even if there's a little bit of a rash. So some people can develop a mild rash. As long as it's not that rash that is debilitating, we're likely going to continue that drug. If they have a little bit of loose stools, then we're likely going to continue that drug. It just, the severity of it would affect your delivery of the drug.
And maybe talk a little bit about, in general, the regimens. So for standard chemotherapy that's given intravenously, how frequently do you get it versus an oral targeted therapy versus an immunotherapy, just in general?
Yeah, so there is a range of how oral targeted therapy is given. Sometimes it's given 5 days in a row every 4 weeks. Sometimes it's given 21 days out of 28 days. Sometimes it's given 14 out of 21 days. It depends on the.
Is that usually a once a day pill?
It's usually a once a day pill, but sometimes it's once a day for 5 days. Once a day for 21 days, once a day for 14 days. The immunotherapy, when it first came out, it was given, depends on the drug. Sometimes it's given once every 2 weeks. Could be given once every 4 weeks,
And
once
that's
every
an
3 weeks, once every
infusion
6 weeks, and that's an infusion.
Uh-huh.
So in certain cancers, they've found out that if you give a fixed dose, it's not weight-based anymore. It's a fixed dose that you can give once every 3 weeks, or you can get every 6 weeks. You're only in the office every 6 weeks versus once every 3. It's really, if it was me and I'm getting treatment, I want to be in the office as less as I can, because I want to enjoy my life. So the benefits of some of these drugs, they're once every 6 weeks.
And then another big category of treatment would be estrogen receptor positive breast cancer, and this thing we call or prostate cancer, where we can obviously breast cancer, a female organ, can respond to estrogen blockers. Prostate cancer can respond to testosterone blockers. And talk a little bit about hormone therapy and under what circumstances. Maybe start with the breast cancer example.
Sure. So I think that dates back to some of the early trials. Are called selective estrogen receptor modulators, or SERMs. The first one developed was a drug called tamoxifen. It's been around for about 50 years, which it blocks the estrogen receptor. So if estrogen's circulating in the blood, tamoxifen binds that receptor, so estrogen cannot bind. And it's revolutionized how we treat estrogen receptor positive breast cancer, because I think the original trials were surgery followed by chemotherapy or radiation. And we've learned over the years that some breast cancers don't really need to receive chemotherapy. So you put them on a pill, and we've had to figure out, how long do you give it for? Do you give it for a year? Do you give it for 2 years? Do you give it for 5 years? Do you give it for 7? Do you give it for 10? I think the data now is 5 to 7 years, depending on the type of breast cancer. And it has certain side effects, hot flashes, because you're blocking that estrogen production. And no matter what age you are, whether you're 30 years old or 70 years old and you're a woman, you're making estrogen, because even fat turns into estrogen. Adrenal glands make estrogen, so it's always there. And that's a medication that we've learned that estrogen receptor positive breast cancer is more of a chronic disease, because you see recurrences sometimes unfortunately, we're seeing recurrences at 3 years, 5 years, even 20 years later. So that's why we treat for such a long time.
Gotcha. Because it's slow growing, and we think that maybe the anti-estrogens or the estrogen blockers don't necessarily eradicate all the cancer cells, but keep them dormant, indolent.
Yeah. So it's kind of like your Lupron in prostate cancer. You're changing the environment within the body. You're kind of cutting off the food supply, so to say. Like in prostate cancer, cutting off the food supply. Prostate cancer feeds on testosterone. So you're reducing that testosterone level so that prostate cancer can't eat. And the prostate cancer goes, well, I can't eat. I guess I'm just going to slow down and kind of become dormant, so to say. And same thing in breast cancer.
And those cancers, the prostate cancers that are still responding to the testosterone blocking, the androgen deprivation therapy, tend to be slow putts along. And the estrogen receptor breast cancers in general tend to be the slower growing of the breast cancers.
They do.
Talk a little bit about, people mention triple negative breast cancer. What does triple negative mean? And what's the significance of a triple negative breast cancer?
So there's basically 4 different types of breast cancer. You have your estrogen receptor positive breast cancer. You have your estrogen receptor negative breast cancer. You have your estrogen receptor positive, progesterone receptor negative. And then you have this other marker called HER2. HER2 is a oncogene. It promotes tumor growth. It sends out signals to make more blood vessels, and more blood vessels means more food for the tumor so it can grow. So there's three things that we look at in breast cancer. We look at the estrogen receptor, we look at the progesterone receptor, and we look at the HER2 new status. So if you have an estrogen receptor positive tumor, you got a target, right? We can block the estrogen, you got a target. If you have a progesterone receptor, you have a target. You have a pill you can use. If you have HER2, that's another target that you can use, and we'll get into that. If you have an estrogen receptor negative tumor, a progesterone receptor negative tumor, and a HER2 negative tumor, otherwise known as triple negative, you don't have a target. All you have is chemotherapy.
So you're back to old-fashioned chemotherapy.
That's all you have. And I always been taught the two types of breast cancer, estrogen receptor positive and estrogen receptor negative. And I remember it was Cliff Hudis, who's out at Memorial Sloan Kettering, just a brilliant breast oncologist. And he said, Christian, there's two types. Kind of a look at it as a mortgage rate. So estrogen receptor negative tumor is a bad balloon up front. Your risk is super high at diagnosis. So you're diagnosed with a triple negative breast cancer, your risk of recurrence at diagnosis is about 70%, if left untreated, surgery alone. Over time, as you reach that 3 to 4 year mark, your risk of recurrence is close to 2 to 3%.
So if you don't get rid of it, you know about it pretty quickly.
It's not a question of if it comes back, it's a question of when, if you don't treat it. Then you have your estrogen receptor positive tumor that is kind of a fixed rate mortgage, right? So if you predict a 1 centimeter tumor, and we look back at the original data, if it's 1 centimeter is a 10% risk. If it's a 1.5 centimeter tumor, 15% risk, so to say. So if it's a 10% risk, it's 10% risk for the rest of your life. It's a fixed rate mortgage. That's why we treat for so long. We treat for 5 years, sometimes 7 years. And some women we may treat longer because we kind of have a inkling that this may be a higher risk and chance of recurrence, that maybe we may want to keep that patient on that longer without any data to support it, but we're just concerned. So
where do you think medical oncology is going in terms of obviously developing new chemotherapy, developing new targeted therapy, new ways of manipulating the hormone milieu, new immunotherapy? Do you foresee from the conference you're going to that there may be a new class of medicines?
Yeah, there is a new class of medicines already, which you're aware of already. There's certain medications that we use for, and it's called RRT, and I'm not RRT. I'm blanking on what it is, but Pluvicto, or this lutetium-177, which is a radiopharmaceutical. It's actually radiation that's infused into the vein, and it circulates throughout the body and attaches to a specific cell. So we have a radiopharmaceutical for neuroendocrine tumors, which is a type of tumor which can occur in the gut and the lung. We have a radiopharmaceutical for breast cancer. There's soon going to be there's one for prostate cancer. There's going to be so many different ways that we'll be able to treat these cancer. And I think some of these treatments are going to be moved up front and possibly ahead of chemotherapy.
Yeah. So the idea here is that the company can make a molecule that will seek out the cancer cell. You can attach a radioactive isotope to that molecule so that the molecule carries the little bomblet to the cancer.
Correct.
Again, try to avoid collateral damage.
Correct.
Don't set off a nuclear bomb and kill all the cancer cells in the patient with it, but try to selectively send the mini bombs just to the cancer cells.
Right. And right now, a lot of those treatments are used in the setting of someone who has progressed on multiple lines of therapy, and this will be their next step. But I think some of these treatments are going to be moved to the front line because of such a great response and well tolerated.
So we'll throw out a word that you're going to hear more and more. And I would say many doctors and even cancer doctors aren't familiar with the word yet, but we're using the word theragnostic.
Theragnostics, that's what it was.
And so, and it's a cross between therapy and diagnostic. So right now we're using radioactive isotopes to do scans, like a PET scan or a bone scan. Those are radioactive isotopes that low dose radioactive isotopes that are carried to the cancer cells, and then you see them on a scan. But with the therapy version, you attach a lutetium-177 or a copper radioactive isotope that gets taken to the cancer cell, but instead of just giving off a little glow that you can pick up on a scan, it actually emits enough radiation to kill the cancer cells. So they've come up with this brand new term, theragnostics, to refer to, because to know whether that little, whether the radioactive isotope that kills cancer cells is going to work, you first have to do the diagnostic scan to see, okay, yes, this molecule that's carrying like the gallium isotope to do the scan can find the cancer cells. Now we'll deploy the radioactive isotope that can actually kill the cancer cell.
Right. Yeah. So I think that's going to be changing. It's very exciting. And I think if we go back to, say, breast cancer as well, 40 years ago, it was chemotherapy. It was chemotherapy. It was chemotherapy. 25 years ago, it was chemotherapy and hormone therapy. And now we're learning too that surgery is becoming an adjuvant treatment, meaning usually chemotherapy was given adjuvantly, meaning given after surgery. So now chemotherapy is sometimes the first treatment, and then surgery is your adjuvant therapy.
So we rely on the chemo to shrink the tumor, get any cancer cells that might have left the tumor and are circulating around the body, and then come in with the surgery after the chemotherapy.
Correct. And so that's what we've been doing for the past 15 years. And now we're learning that maybe some cancers don't need chemotherapy. Maybe you can use a hormone manipulation. Maybe you can use other medications which help upregulate that estrogen receptor to allow other medications to block it greater. And there's been numerous studies looking at that they're equivalent to chemotherapy. You don't have to subject someone to chemotherapy. You can subject them to a different type of pill or 2 pills, and you get a better response.
So some of our research isn't about just doing more, but if we've already achieved 95% success rate, maybe we can back off. And so some of the studies we're doing are de-escalating the treatment because we are so good at getting rid of the cancer, but we've got lots of side effects. Maybe backing off a little bit, we can have the same cure rate with fewer side effects.
Yeah, there's been, I think one of the first trials in breast cancer, I think it was the Pertain trial. It was the first trial with a chemo-free regimen in metastatic breast cancer, and it was the use of Herceptin with anastrozole, which is a drug that blocks estrogen. And it was equivalent to the use of chemotherapy with a significant improvement in survival. Mm-hmm. So, yeah, the de-escalation trials, I think, are fascinating because using less toxicity, proving quality of life, we're not making inferior improvements in survival because it's the same.
When we started the conversation and you mentioned that you don't view what you do as a job, that it is really a ministry of healing. And you talked about how much you enjoy establishing the relationships with patients. Talk a bit about what it's like to be a cancer doctor, to have to talk about mortality and prognosis. And besides your chemotherapy, targeted therapy, hormone therapy, immunotherapy, what skills do you have that help heal patients?
Well, I think a lot of it is just having that personal communication with them so they know you're there. You're here for them. It's support. It's that ability that I can contact Christian at certain times during the day because he allows me to. And just having that ability or knowing that it's there, that alone is just a good feeling for them. Other thing is pain control. We're there for just support for their family. I think those are the main things that we're going to do.
The psychosocial support. But you think you're absolutely right. It's the relationship in and of itself is healing.
It is.
I mean, the number of times that you talk to a patient and they say, I just feel so much better after talking to you. And you might have even just given them news about a scan that wasn't all that favorable, but in such a way as you here's what we're going to do.
Yeah.
Here's our options. Here's what we can do to move forward.
Yeah, I think is that you go into that room, you're giving bad news. Obviously, that patient and the family are going to take that poorly, but if they leave with some set of hope, which I think is the goal, is that hope to treat that cancer again? Is that hope to enjoy my life, whatever it may be, in a quality way? Is the hope that I'm just going to feel good? I mean, that's your goal. Ultimately, your goal is quality of life and making those patients feel good, whatever it may be.
Maybe describe how you were challenged. We were all challenged during COVID, how the way we were taking care of patients and, not allowing family members to come in and trying to, we were doing everything to try to do the right thing, to try to make sure that patients that are immunosuppressed at high risk for COVID don't get it. But in the process, what did that feel like for you? What did you experience during COVID as an oncologist caring for patients?
Well, it was tough because what we did was we didn't want all our doctors in the hospital, because then if we all get sick, we can't see people in the office. So what we changed was, for 1 week, I would be in the hospital and I would take care of all the patients. And then 1 week I would be at home doing telehealth and I wouldn't see my patients. Then I finally be back in the office. So that was tough. And you'd be limiting the amount of patients you're seeing per day.
Mm-hmm.
And what do you do with a patient who had chemotherapy and they have a sore throat and they're running a fever? You have to see them. You can't say go to a COVID clinic.
Mm-hmm.
You have to see them. So, and it was tough to figure out, what do you do? Did this patient get chemotherapy? Well, we got to see him. Well, he didn't get chemotherapy, so we don't have to see him. Well, you did everything you could to take care of the patient, but it was not enjoyable.
No. And another difficult thing was limiting the number of people that could come with the patient, and having an extra set of ears and having support. To have to go through this solo is really difficult.
That was hard. You'd have a phone with a bunch of different family members, but it's not the same because they're not having someone pat in the back. They're not having someone. It was extremely, it was sad.
So I didn't ask you this, but back at the beginning, so your dad was an emergency room physician. When in your medical career did you think of oncology as the specialty you were going to go into? Was it even before you went to medical school, or was it during your training based on just some favorable rotations or some mentors that you had?
I think it was multiple. I look back when I was a kid, my dad would always bring home slides of blood. And being a hematologist, you look at slides of blood in the microscope every day. There's not a day they're not
why
looking.
was your dad, the emergency room physician, bringing blood from the ER to your house?
Well, he got me a microscope, so you had your insects.
Oh, okay.
And so he brought those home and said, hey, let's look at that. So we would look at blood together.
Okay.
And I didn't know what the heck I was looking at. And then, so first year I'm in the Caribbean, and then my second year I'm there, and my third year I'm in London. And my wife, my girlfriend at the time, calls me, and she lost her hearing. She had a terrible episode of vertigo, and she was very sick and had to be taken to the hospital because she could not stand up straight. She wasn't drinking. She was just vomiting and very dizzy. And it was about 3 months after that, she lost her hearing in her left ear. And so she went to an ENT doc in Cedar Rapids. I won't forget her name, Dr. Brzezinski. She was amazing. And she goes, yeah, you probably had a virus. Your hearing's not going to come back. Any questions? She goes, oh yeah, by the way, I got this lump here. She had this huge lump in her neck. And Dr. Brzezinski goes, it's probably nothing, but I'll biopsy it. Ended up being thyroid cancer. And so at the time, being a third year medical student, I knew everything. I said, don't worry about it. But Angela got her thyroid out, and she had locally advanced thyroid cancer with lymph node positive disease. And that was one reason.
About 30.
She was 24.
24, okay. And you were in London.
I was in London at the time. Yeah. So I didn't know anything. So that was one reason.
That was one reason.
And then in England, it's kind of interesting how you do medicine. So you're a medical student, and when you do your so-called residency, you become a house officer, which is kind of a first-year resident. And then your next year, you become a senior house officer. And you may remain a senior house officer for years unless you're allowed to take your boards. Then you become what's called a registrar, which is kind of a chief resident. And then after a registrar, you take your boards and you become your FR fellow of the Royal College of Physicians. You become a consultant. So when you're a house officer, senior officer, house officer, registrar, you're Dr. Deming. Once you're a consultant, you're Mr. Deming. Okay.
So in the hierarchy, Mr. is a higher.
It is a higher thing.
Honorific than doctor.
So when I was in my third year in London, I got to work with Miss Lydia Jones, who was the medical oncologist at Epsom Hospital in Epsom, Surrey. And I saw my first patient with cancer, and she explained things to me, and I was hooked. So it was Miss Lydia Jones and my wife Megan that pushed me in the way.
And at that point in England, in cancer care, had it already gone to mostly outpatient?
A lot of it was still inpatient.
It was still inpatient.
Yeah, because this was 1995, 96. A lot of it was still given inpatient.
Okay.
Yeah.
Well, let's open it up some questions, because I know we got a live studio audience here. We also, if you're watching us live streaming, you can put your question in the comments section, and we'll start with our live studio audience. Angelina.
Hello. All right, I have a question about all the hormone therapy type drugs. What if you have a patient, not saying it's me, but it could be, has tried everything from letrozole, all these other, and I've had reactions to them. And we're down to probably, what's it called, tamoxifen? We haven't gotten there yet. It's bad reaction. You know, when they give you the studies of the low percentage people that had certain, I end up getting those percentages. What if I decided I don't want to do that because of my quality of life? I mean, it was debilitating. I couldn't, it was almost like arthritis, kind of really hard. Would I be okay if I chose not to, or is it dangerous to think that?
That's a tough question, because I mean, I guess it depends on the stage of disease, depends on the grade of disease, depends on the size of the tumor, depends on the lymph node status, depends on a lot of different things. So if I've had several women that I've tried anastrozole, then I've tried alestrozole, then I tried exemestane, then I tried tremophene, then I tried tamoxifen, and they're unable to take it. And I tell them, we tried, we're going to watch closely, and God forbid if something happens, we address it at that time. In the setting of metastatic disease, there's been several studies that you can look at other things besides estrogen receptors. You can look at the androgen receptor, because androgen receptors, you can have an androgen receptor positive breast cancer that, you know, sometimes you can use enzalutamide, which is a drug that we use in prostate cancer, and it works in women with breast cancer. We actually used to use, seems odd, we'd use a drug called diacylstilbestrol, which you remember, DES, which was an estrogen-like drug for breast cancer, typically in metastatic disease, but we don't use it anymore because the side effects are so awful. So, and say you're having metastatic breast cancer and you're having terrible hot flashes related to the drug, sometimes given a shot called the Depo-Provera shot, and that sometimes can help with hot flashes, and it's shown not to affect the breast cancer specifically. So I think really depends on the several different factors associated with breast
one
cancer.
of the big distinctions I'm hearing you say is, are you taking the medicine because you have stage 4 disease that's not curable, or are you probably cured of cancer, but you're taking the anti-estrogen type medicine to reduce the risk of it coming back?
Right.
So when you're taking it as extra treatment that you may not need, then there's a little bit more leniency in saying, well, yeah, I want you to do this for 7 years, but if you, you're alive, but just wish you were dead because you're so miserable, well, then, yeah, that would be the situation where, looking at the risks and benefits. But if you are incurable cancer and you need the medicine to kind of stay alive, then many patients might be willing to put up with more side effects when they know that it's actually treating cancer as opposed to it's just extra treatment to lower the risk.
And then going back a little bit further on that, so recent studies out of the UK are looking at tamoxifen at lower doses. So tamoxifen is usually given at 20 milligrams, right? It's a higher dose. So they've looked at studies in Europe that they're using 10 milligrams of tamoxifen with similar results. And there was a trial done in the United States for prevention on certain markers that not breast cancer per se, but markers that increase the risk of breast cancer, that 5 milligrams of tamoxifen was just as effective. So I have patients that if they can't tolerate 20 milligrams tamoxifen, I'll do the 10. Say you didn't tolerate anastrozole. Could you try it once every other day? Could you try it once every third day to see what we could do? There's a lot of options you can try.
With women that haven't gone through menopause yet, that still have ovaries that are putting out a lot of estrogen, an option would be to, instead of giving lots of medicines to counteract the estrogen or to block it, is to remove the source of the estrogen, to remove the ovaries.
Another question on that tamoxifen, there's a possibility of blood clots.
The risk of blood clots, when we look at the original trial, I mean, the side effects with tamoxifen are going to be hot flashes, blood clots, small risk of uterine cancer, which I've never seen in 25 years, cataracts. The risk of blood clots is about 1 in 1,000, but I've seen blood clots quite a bit in tamoxifen. So a lot of the times, if I have a patient that's going to be on tamoxifen, I need to know their family history. Is there a family history of clotting? And if there is a family history of clotting, potentially looking to see if you have a hereditary defect. And if you do, maybe tamoxifen wouldn't be your best choice. Any patient that I have on tamoxifen, I always put them on a baby aspirin. I don't know if it's been proven to be effective, but in those patients, I haven't had too many clots.
How about somebody who's a diabetic and that concern? Being a diabetic would be
with tamoxifen?
Yeah.
I'm
not a smoker, but
I don't know if that would be a huge negating factor in using that. I don't think it would be.
Poon, do you have a question?
I'm 6 years out from treatment, lobular cancer, ER positive, HER negative. So I'm still on tamoxifen because my tumor was over 4 centimeters. So at year 5, my oncologist was thinking of, okay, let's test your tumor to see if you should still be on tamoxifen.
Oh, the tumor index, the breast cancer index.
Yes. However, they can't find my tumor. So don't want to get anyone in trouble, but
they usually keep the block for about 15 years.
Right. So,
interesting.
So is there anything new, any way of testing to see other than that tumor? And the other thing on the tamoxifen, since you mentioned that, is it something maybe I should talk to her about going to 10 milligram of tamoxifen?
Well, I guess the more of the question I ask is why aren't you on an aromatase inhibitor? That would be my question.
I did not go through menopause prior.
So I think at least the average age of menopause now is, I think, 52. So I typically will not use an aromatase inhibitor in a woman who's less than 52. I'll use it after that. Checking hormone levels in the blood, that checks it that day. Doesn't check it the next day. And doesn't check the next month. So if you check your estrogen levels, you're postmenopausal. You're postmenopausal that day. So if you have a 44-year-old woman and you're checking estrogen levels, you're at postmenopausal status. They're not. So in a postmenopausal woman, I think it was the Big I trial that in women who are higher risk and postmenopausal, 5 years tamoxifen followed by 5 years of letrozole was probably the biggest data. I think 10 years of tamoxifen has primarily been used in premenopausal women. I think that 10 years of tamoxifen, if 20 years of tamoxifen is fine in someone who's postmenopausal, because if you're tolerating it well and you're not having any issues, I think that's an appropriate choice. If you've done well on tamoxifen and you haven't had any evidence of recurrence, yeah, I mean, I think that's a discussion you can have with your doctor. Your doctor's not going to make that decision alone, and you're not going to make that decision alone to go to 10 milligrams. But if I had a discussion with my patient saying, I don't want to be on this 5 more years. This drug sucks. I don't want to. Well, before you stop it, let's try to go down to 10 milligrams and see how well you tolerate it. And we'll continue to follow things closely and watch. I think it's very appropriate, but that's a discussion you have to have with your doc.
Right. I would.
Yeah. But I think there's a lot of options you have.
We have time for one more question for Dr. Schultheis. Here we go.
You mentioned early on that it's exciting, the cutting edge drugs, but the high cost of these drugs, is cost a factor in treatment? Is it in the consideration set, and should it be? And are you concerned about that?
Well, it should be, but unfortunately, these drugs are so effective that I wouldn't want to withhold a drug from a patient because it was cost prohibitive unless I can't get that patient a grant. If I can't get that patient a grant, I'm not having them pay $22,000 a month, because some of these drugs cost $22,000 a month. It's absurd. But if that drug is so beneficial, I'm going to do everything I can to either get a grant or you get it free from the company. I had a patient back in Dubuque that his insurance coverage lasted 6 months. After that, he was responsible for the drug. So I got him free drug for the rest of his life from the drug company. They were able to do that. So I think there's ways that you can help out, but I would not want to withhold a drug based on cost, because these drugs have been revolutionized in how patients are treated, and just the response rate can be extremely high.
Great.
I can answer that question. Verlidia, I don't know if you've heard of that drug or not, but it protects the pituitary gland and it stops the testosterone. And because of that, my what am I trying to say here?
Your insurance company.
No, well, my insurance company, I had it for a lot of years, 2 or 3 years, and all of a sudden, boom, kicked me off. I found out I was on Medicare, and they're doing everything they can to get that drug free for me, because they're using a grant from a large company, like you said. That's a life-saving drug for me, because it's brought my prostate cancer down to almost zero.
Mm-hmm.
You know, so I think it's really important to be able to have that available. And I know they work really hard to try and get you help if the drug is just outrageous.
Oh, they do. And like I said, at Mission, our pharmacy department has, I think every year they get close to $3 million in grants for patient medications. It's just fantastic.
Yeah, it actually saves lives.
It does.
Well, Christian, thank you so much for being here. This was awesome. If you're watching and you know someone that would benefit by watching this program, it's going to be available on demand tomorrow. You can watch it anytime you want on the Above and Beyond Cancer YouTube channel, or you can go to the Mercy Cancer Center website and you can find a link to watch this program. So thanks for being with us tonight.
Thank you.
I hope you guys will join us again next week. Thanks, everyone.